Welcome to segment 5, where we will be covering Child CPR. What does the acronym CPR represent? C is for cardio, meaning related to the cardiovascular system, or more simply put, the heart. P is for pulmonary, meaning related to the pulmonary system, or more simply put, the airway and lungs. R is for resuscitation, meaning reviving someone from unconsciousness or death. When we determine that someone needs CPR, we have identified that there is an issue with the heart, airway, and lungs that has caused this patient to become unresponsive or dead and in need of revival. The most common reasons that children and infants go into cardiac arrest differ from that of an adult. Children and infants have not had the lifespan to develop conditions such as hypertension, coronary artery disease, and cardiac arrhythmias. Unless the child was diagnosed with a form of congenital heart disease, the most common reason that they will go into cardiac arrest will be an issue involving their respiratory system. Look for something immediately fixable with your child's respiratory drive, such as something covering their airway if they appear to be in severe distress. As stated previously, children traditionally compensate well for significant clinical illness, but when their compensatory mechanisms fail, they decline rapidly. Ensure that the scene is safe prior to approaching the child. Situational awareness is key. As the rescuer, your own personal safety is always of paramount importance. You are the one that possesses the skills necessary to provide care to the child experiencing the emergency. If you enter an unsafe scene, you are risking potentially harming yourself and in turn not being able to help the child in need. Take 10 seconds time to assess the situation and rule out any potential hazards before initiating patient care. Check the patient for responsiveness. We need to check responsiveness on a child who is unexplainably lying motionless with their eyes closed. First, try to stimulate them verbally by saying a phrase that they would normally respond to, such as calling them by their name or asking if they are okay. Hey, are you okay? If they are not responsive to you talking to them, progress to attempting to stimulate them painfully. Use your pointer and middle fingers to tap them vigorously on their collarbones. There is little to no fat or muscle covering the collarbones, and the tapping should prompt the responsive child to moan, groan, open their eyes, or move a limb. If the child does not respond to your attempt at a painful stimulus, you have now determined that they are unresponsive. An unresponsive child is a major medical emergency. At this point, it is imperative that you dial 911 immediately. If you or someone that you're with have a mobile phone within arm's reach, dial 911, place the phone on speaker, and lay it on the floor next to you. You have now alerted the dispatcher that help is needed, and first responders will be en route to your location. You will also have your hands free to perform interventions. 911 dispatchers are formally trained to coach people through performing CPR. If you find yourself unable to recall the proper steps, the dispatcher will prompt you as necessary. If you are alone and do not have a phone readily available, continue your assessment of the child prior to attempting to dial 911. If you determine that the child needs CPR, perform 5 cycles of CPR prior to attempting to locate a phone. Determine if the child is breathing normally. We assess the status of a child's breathing by observing their chest. When a child lays on their back, if they are breathing, we should see their chest rise as their lungs inflate. While assessing the child's breathing, if the chest is rising low and slow, or not at all, they are not breathing normally, and we will initiate CPR. A child's heart and lungs are both significantly smaller than an adult. This means that their normal heart rate is higher in comparison to an adult, and their respiratory rate is higher in comparison to an adult. When a child is not breathing normally, it will cause their heart rate to fall to a point where their vital organs are no longer receiving the blood and oxygen required to prevent cell and tissue death. Therefore, CPR is performed on a child that is unresponsive and not breathing normally. The landmark for hand placement on a child is the center of the chest just below the nipple line. Use one arm only if you can perform the adequate rate and depth of compressions. This is usually for patients ages 1 to 8 years old, depending on the physical capabilities of the rescuer. If you cannot perform the adequate rate and depth of compressions using one arm, use 2 arms to perform compressions. Keep your elbows locked, your shoulders directly over your hands and use your hands as a focal point on the chest to redistribute your body weight. A common mistake is bending the elbows and using the muscles in the arms to deliver compressions. This is not a sustainable technique. There are two components to an effective compression: rate and depth. The rate is how many times we compress in a minute. The appropriate rate for child compressions is 100 to 120 compressions per minute, or about 2 per second. It is physically impossible to effectively compress faster than that, so simply put, compress fast. The depth of compressions for a child is about 2 inches. How do we accurately gauge that unless someone is using a ruler to measure our compressions as we are performing them? Simply put, we compress hard. Will compressing hard cause damage to the child? This question requires a simple risk versus benefit analysis. We are performing CPR because the child is either dead or near death, and death is permanent. Broken bones and bruises will heal, so the benefit of performing compressions hard outweighs the risk. The cracking noise and feeling experience is most often from the cartilage that connects the ribs to the sternum. Your rib cage is not meant to be forcefully pushed on. This can be compared to the cracking noise and feeling your knuckles make when you press down on them. The heart is a pump. 24 hours a day, 7 days a week, for the duration of our lives, our heart continuously fills with blood, then contracts to push the blood out into circulation. When a child is in need of CPR, that means that either the pump is not working effectively or has stopped working completely. When there is insufficient blood flow in the body, cell and tissue death begins to occur and the damage is irreversible. We deliver a compression in effort to keep blood flowing, mainly to the vital organs, so that the child has a chance to be revived. Therefore, it is imperative that we have the child lying on a hard surface and that we push hard when we deliver a compression. If we do not push hard when we compress the heart, we are not creating sufficient blood flow. In addition to pushing hard, we need to allow the chest to recoil in between compressions. The recoil phase is when the heart refills with blood. If we do not allow the chest to recoil in between compressions, there will not be enough blood in the heart to push out into circulation. A ratio is a relation between two amounts showing the number of times one value contains or is contained within another. The ratio for compressions to rescue breaths is 30:2. You will deliver 30 compressions fast and hard prior to opening the airway and delivering 2 rescue breaths. When someone who is unresponsive lies on their back, their tongue can fall against the back of their trachea, obstructing their airway. To displace the tongue from the back of the trachea and create an open pathway for the rescue breaths, place one hand over the forehead and one hand underneath the chin while tilting the head back. To deliver rescue breaths using the mouth-to-mouth technique, pinch off the child's nostrils and completely encircle their mouth with yours, creating a tight seal on the face. Turn your head to face the child's chest and deliver a total of 2 consecutive breaths. Each rescue breath should only be given to the point of seeing the chest rise. Adults generally have a much higher lung capacity than that of a child. To avoid overinflating the lungs, stop the rescue breath at the point of seeing the child's chest rise. There should not be a longer lapse of more than 10 seconds between compression cycles once chest compressions are initiated. While performing chest compressions, you are building up needed pressure in the child's vasculature. When compressions stop, that pressure drops. Additionally, when compressions aren't being performed, there is no blood flow or oxygen delivery to the vital organs. Without blood flow and oxygen delivery, the vital organs begin to experience cell and tissue death that is irreversible. Continue to perform cycles of 30 compressions to 2 breaths until either first responders arrive or the child becomes responsive and is breathing normally. If there are 2 or more people present that are trained in CPR, one person can be responsible for managing the airway and delivering rescue breaths, while another person performs chest compressions. Once the rescuer delivering chest compressions begins to tire to the point of no longer delivering adequate compressions, they should verbalize to the other rescuer that it's time to switch roles. Maintaining effective compressions is always the #1 priority when performing CPR. If you do not feel comfortable performing rescue breathing using the mouth-to-mouth technique, perform hands-only CPR instead. Hands-only CPR is delivering compressions only at a rate and depth that is fast and hard until first responders arrive or the child becomes responsive and is breathing normally. Ensure that the scene is safe. Hey, are you okay? Hello, 911? They're not breathing normally.